Yeah, good afternoon, everybody. Welcome to this afternoon episode of Pursue 5R, which is General Pathology and Neoplasia. And before we start, a very happy new year to everybody. And today we have again Dr. Major Palash Kumar Mandal, who's an associate professor in pathology in Sagore Dutta Medical College, Kolkata. I'm lab director in the famous Desun Hospital and Heart Institute, Kolkata. And today he will be talking on neoplasia, and this will be session 1. Before I ask him to start, let me ask you to request you to keep your mic muted, your camera off, and please don't share your screen. With this, let me ask, sir, please start.
Sir, there is an echo which is going on.
Okay, I'll sort it out. I'll sort it out. No problem. Yeah, I can see your screen.
Good afternoon, everybody. Sir, again that echo is coming.
Okay, just 1 second, please. Yeah. Is it okay now?
Good afternoon, everybody. No, sir, again the echo is there.
Oh, it will go away. Just carry on.
Okay.
It will go away.
Okay. So, we wish you a very happy new year. And today we begin with a very important topic, that is neoplasia. This is the basis on which the whole oncology stands, the oncopathology stands. So I request all of you who are attending today and who will be listening to this lecture in future on YouTube, please take note of this lecture and the subsequent lectures on this same chapter, neoplasia. I will talk more like an undergraduate lecture, more like an undergraduate lecture, because in systemic pathology this same neoplasia will be dealt by different speakers as per the system is there. Okay, so now we begin with general pathology neoplasia. To begin with, just hold on.
Yeah, no problem, no problem.
So with this, we have an introduction to the topic, the definition of neoplasia, which is very important and often asked in the viva table, the difference between benign and malignant neoplasms, the difference between carcinoma and sarcoma, the invasion and metastasis of malignant neoplasia, and a general idea of what the nomenclature regarding these neoplastic lesions are. So first, neoplasia, what does it mean? Neo means new, plasia means growth. So simply put, neoplasia means new growth. However, if you are asked the definition of neoplasia, this is not enough. Okay, many students, they just say that neoplasia, new growth. Well, you have to give the full definition. As per British oncologist Willis, the definition of neoplasia is that a neoplasm is an abnormal mass of tissue. It is given in all the books, Robbins, and I think even in Hirschman this definition is there, which is worldwide accepted definition. A neoplasm is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of the normal tissues and persists in the same excessive manner after the cessation of the stimuli which evoked the change. This is the complete definition, and I request you to remember the definition. Not only this definition, I tell all my undergraduate students, please write down all the definitions of general pathology in one area of your notebook, at least 5, 7, 8, 9, whatever pages it requires. Please write down all the definitions, because before going for the viva examination on the day of the practical, you will definitely need them, and even before theory also, because often they come as the first question, define neoplasia, then they will say the other question. Okay, so this is the definition, and tumor originally applied to a swelling caused by the inflammation, but non-neoplastic usage of tumor has almost vanished. This is a very important thing. Actually, you see, when the terminology we read about this inflammation, you had this things about tumor, dollar, calor, and this functionalisa. So all these things were there. Okay, so that was only applied to new inflammation at that point of time. However, the tumor word has now been only associated with neoplastic change, and neoplasm is not just cancer, it is also a benign growth. Okay, so anything, an abnormal growth which is looking uncoordinated with the normal area, which is exceeding the growth of the normal requirement of the tissue, is something called tumor or neoplastic lesion. Okay, and oncology is the study of tumors or neoplasm. In Greek, onkos means tumor. And as I was telling you, neoplasm, don't think or confuse neoplasms to be malignant lesions always. So neoplasms may be benign when they are slow growing, localized, without causing much difficulty to the host, or they may be malignant. That is the danger one. So when they proliferate rapidly, spread throughout the body, and may cause the death of the host. And common term used for all malignant neoplasms is actually cancer, which means crab, and Hippocrates coined the term carcinoma for cancer of the breast. And Hippocrates, as you know, long time back in BC, around 460 to 377 BC, he survived. So during that period, he coined that term. So these are the pictures taken from books or an internet, actually, not book. So this particular thing is a tumor or a growth. You see, this is a person who is having a swelling on the upper part of the back. This is the scapula, this is the back. So this is fairly a round tumor. It can be benign or it can be malignant. But from the look of it, it may appear benign because it is a small lesion. However, when you compare it with this lesion, this is the actual photograph taken during the OT. So who had this large lesion in the left scapular region, and you see such a large lesion can actually very rarely be benign. It most likely is a malignant lesion. So this turned out to be a liposarcoma after histopathology was done, and this was proved to be a case of a benign tumor of the adipocyte, that is lipoma. Same thing here. You see why I am showing you the pictures. Please have an idea from the look also. You can see which is a benign lesion or which is a malignant lesion. This is a small lesion on the face of the person. Okay, so this is a neurofibroma, and the same lesion, the malignant counterpart in this person, which has eroded the local area and caused a lot of destruction to the local area and looking like a raw mass. So that is a malignant peripheral nerve sheath tumor. Similarly, we have this adenoma of the colon, teratoma of the. These terminologies are basically to give you an idea that there can be benign neoplasm, there can be malignant neoplasms, and all tumors, they have two basic components. Any tumor, they have two basic components. One is the clonal neoplastic cell, that is the parenchyma. Okay, because the neoplastic cells, they have a clonality, means they originate from the same clone. Their original father or mother is the same, and they have proliferated. That lineage that has proliferated, so their clonality, this the genetic changes in that particular clone of cells is same. So naturally some mutations might have taken place. Which gene, which chromosome, we don't know, but just giving you an idea that whatever mutation is there in a one neoplastic cell will definitely be present in the adjoining neoplastic cell also, but it will not be present in the normal benign cell which is there in the background. Okay, so please try to understand. So these are clonal cells. There is a clonality which is maintained. The genetic structure of all these neoplastic cells are same. Number one, the reactive stroma made of the connective tissue, blood vessels, and variable number of macrophages and lymphocytes are present also. So one is the parenchyma and second is the stroma. Stroma, why it is necessary? Because stroma provides the growth for the nutrition for growth. So that is very vital. Why the inflammatory cells? Because they also play active role in producing the microenvironment of the area, the environment which is necessary for the growth of the tumor. And there are also some cells which try to prevent the growth of the tumor. So those are the body's reactive cells. They try to prevent the growth of the tumor. But if it is a malignant tumor, they actually do not succeed. If it is a benign tumor, however, they may keep the growth they restrict the growth to certain extent, but may not be successful always, even in a case of benign tumor. The benign tumors also can take large shape and size, I mean large size, and dimension can be different also. And the suffix oma is added to denote a benign tumor. And malignant tumors of epithelial origin are called carcinomas, while malignant mesenchymal tumors are called sarcomas. Sarcos means fleshy. So this is the nomenclature. You see, you have to have an idea why these terms are used, what are the terms for the various neoplasms of our body. So this terminology is very, very important. Okay, so whenever you are going and examining a patient, some other doctor has, a senior doctor has written some diagnosis of some malignancy or a benign lesion. So you have to understand what does it mean actually. Okay, because there may be the relatives of the patients who might be asking you. You as a junior doctor have gone there alone. So the juniors, the relatives of the patients may be asking you, doctor, what does it mean? So you should yourself have a clear idea what the actual thing is. Is it a benign condition or a malignant condition? If it is a malignant condition, what type of malignancy it is? Okay. Now classification. So this is important in the sense you have to understand there are epithelial neoplasms, there are mesenchymal neoplasms. So tissue of origin is very, very important because the behavior of the tumor depends on the tissue of origin to a large extent. Okay, behavior means the pattern of growth, behavior means the sensitivity to a particular chemotherapeutic or radiotherapeutic agent. This is known as the behavior of the tumor. Okay, so epithelial tumors, squamous cell carcinoma, squamous epithelium, squamous cell papilloma, and squamous cell carcinoma. Sorry, this carcinoma should have been on the right. It is due to printing mistake or some this thing, it has come here. So squamous cell papilloma or squamous cell malignant counterpart is squamous cell carcinoma. Transitional epithelium, papilloma, carcinoma. Glandular epithelium, adenoma, adenocarcinoma. I showed you one picture of intestine. So basal cell layer of skin, neuroectoderm, nevus, malignant melanoma. These terms are there. You can read up in the book, internet, everywhere these terms are there. I will be sharing my lecture with you also. I don't want to repeat one by one all of them. And in mesenchymal tumors, we have that we showed you an example of lipoma, liposarcoma, fibroma, fibrosarcoma, cartilage chondroma, chondrosarcoma, bone osteoma, osteosarcoma, so on and so forth. So for skeletal muscle, the name is a little different, rhabdomyoma and rhabdomyosarcoma. So it is asked at times in the what is the benign neoplasm of skeletal muscle? So that since the term is a little different, you have to remember. Similarly, smooth muscle tumor is known as either leiomyoma or leiomyoma, whichever you want to pronounce, and leiomyosarcoma. Okay. This continues. I am not going to repeat. Mixed tumors. They were the single cell tumors. Now mixed tumors of salivary gland, pleomorphic salivary adenoma. So pleomorphic adenoma, it contains multiple types of cells. Okay, multiple types of there are multiple components. That's why it is known as pleomorphic. Means there are different type of cell. The one cell looks different from the another cell. So pleomorphic. And malignant counterpart is malignant mixed salivary tumor. If it is more than one germ cell layer, this pleomorphic adenoma may not be necessarily from more than one germ cell layer. Okay, so that is why it is not a teratoma. Whereas the tumors which have the origin is from more than one germ cell layer, they are called teratomas. So benign can be mature teratoma, malignant can be immature teratoma. Okay, mostly seen in the gonads and embryonal race. Okay. So characteristics of the tumor, what I was telling you is the behavioral patterns or characteristic of the tumor can be seen or can be studied by these following parameters. Okay, number one, the rate of growth. Number two, differentiation and anaplasia. Differentiation means the tumor, the origin of the tumor needs to be understood. As I told you, we have to understand which lineage it is coming from. Is it a epithelial lineage? Is it a mesenchymal lineage? If it is epithelial lineage, what type of epithelium? Squamous epithelium, glandular epithelium. Is it a if it is a mesenchymal lineage, is it a adipose tissue lineage or a nerve tissue lineage? So we have to identify this thing, because the chemotherapy is very specific these days. If you can correctly identify a particular tumor and also study its the genetic change in that tumor, you can correctly give the chemotherapy. Okay, so that is why we need to understand the cell of origin. Very important. Anaplasia, what does it mean? Anaplasia means total this loss of differentiation. This is just the opposite of differentiation. Loss of differentiation is anaplasia. The cells are totally aggressive looking, very pleomorphic, means one cell looks different from the other. There is the nuclear chromatin becomes very condensed, nucleoli are there, cells may have multiple nucleoli. So that those are the features of anaplasia. We will come to it. Okay, so anaplastic is just the opposite of well differentiation. Okay, now clinical and gross features. So clinical features means what are the clinical findings? If a growth is small and is not harming the person as such, the growth appears to be benign. Whereas suppose a growth has happened in a place and it has caused compression of the nerve. Suppose a growth has happened in the area of the face and it is causing ptosis of the eyelids. The eyelid becomes semi-closed. It is called ptosis. P-T-O-S-I-S. Ptosis. So it is causing ptosis. So we can think that is there infiltration of the growth into the nerve sheath. So is it a malignant lesion? So these are indications. So clinical behavior, gross features means the size, the shape, and if it is attached to the adjoining structures, or is there a capsule, or are there areas of hemorrhage and necrosis. These are called gross findings. Okay, coming to microscopic features, we as pathologists, we have to this is the bread and butter for all of us. So we have to understand, we have to see and examine and ultimately diagnose on the basis of the microscopic features. Okay, clinical, gross, all features will give you an indication, an idea that this could be this, but final diagnosis has to come from the microscopic features only. We can resort to special investigations like immunohistochemistry, cytogenetics, etc. But the basis is the hematoxylin and eosin stain slides for the pathologist to diagnose a particular lesion. Fine. Local invasion, that is direct spread to the local area. Metastasis, that is distant spread. These are all the characteristics of tumors. And metastasis, of course, is not a finding for a benign lesion. It is only seen in case of malignant tumors, though metastasis can be seen in some benign lesions. That is a very rare thing, but for all practical purposes, whenever the term metastasis is used, we think the antenna is there, that it is a malignant lesion. Fine. So this is what I was telling you. I have already explained to you what differentiation means and what lack of differentiation is. So I am not repeating this. So this is a mature these are the pictures of mature adipocytes. This is a hand-drawn diagram, and this is the actual photomicrograph. These are the adipocytes. The actual stain does not take place within the fat cells because the fat is washed away by the reagents or the chemicals we use during the processing of the tissue. Okay, during the processing of the tissue, when we try to embed it or make a paraffin block from it, the fat actually washes away. Okay, so hence if we want to stain fat, we have to use a different method, that is take a frozen section and do a staining of fat. Okay, so otherwise fat already appears as open empty spaces. Anaplasia, what does it mean? I have explained it to you, but if you are asked in your viva table what is anaplasia, literally it means to form backward, that is a reverse differentiation to a more primitive level. In well differentiated tumors, the daughter cells are derived from the cancer stem cells, retain the capacity for differentiation. Means a lipoma looks like all the cells of the lipoma look like normal adipocyte. Okay. However, if it becomes a liposarcoma, this capacity to look like its parent cell does not happen. So parent cell, that is the adipocyte, will not have resemblance to a de-differentiated or a very poorly differentiated liposarcoma. Okay, so that is the meaning of anaplasia. So differentiation is lacking. Okay, so these are the morphologic features of anaplasia which are often asked in your viva table. What are they? First is the loss of polarity. Polarity means the orientation of the cells in a particular area. Suppose we have a squamous epithelium. The lower layer, that is the basal cell layer, they are little large. Okay, a little roundish. The nuclei appears a little large. However, when they start going upwards towards the surface, they become flattened. The nucleus becomes small. The cytoplasm becomes more. So that is called polarity. Okay. So we similarly in the glands, there are the luminal cells, there are the basal cells. They have got different shapes. Okay. That is polarity. So in anaplasia, this polarity is lost. So in surface also you will see large cells, large rounded cells with large nuclei. So that is called loss of polarity. Pleomorphism, this term you may have heard several times. This means variation in size and shape. One cell will have a different size and different shape from the rest, another cell of the same tumor. Okay. Abnormal nuclear morphology. Characteristically, the nuclei contain abundant chromatin and are dark staining. The nuclei are disproportionately large for the cell, and nuclear cytoplasmic ratio may be high. Okay, large nucleoli may be present. So these are the nuclear characteristics. So nucleus is the site of that is called, sorry, proliferation. Okay, that is the site from which cell division happens. Chromatin is there. The nucleus is the site where the DNA is stored. So everything, the neoplastic cell will always have a large nucleus because more chromatin is needed for expansive growth of the tumor. The more malignant it is, the dense nucleus it has. Okay, so hyperchromasia, because it has got more chromatin. More chromatin is necessary for cell division. Fine. So the nucleus is large. This is in a short called high NC ratio, high nucleocytoplasmic ratio. Normally nucleus is almost maybe 1/3 to 1/5, depends on the particular type of cell. Suppose a hepatocyte will have a large nucleus, whereas a superficial squamous cell will have a very small nucleus. So it may also be 1/10 of the cell size of the cell, but it may approach 1:1, that the nucleus becomes so large, the cytoplasm and nuclear area become almost the same, and they may have large nucleoli. You may see mitosis. large number of abnormal mitosis, that is tripolar, quadripolar, multipolar, circular. These mitotic figures indicate, abnormal mitotic figures indicate that this is a malignant cell. Okay, so all these characteristics are cellular characteristics. Okay, other changes: formation of tumor giant cells, huge polymorphic nucleus, others may have more nuclei, hyperchromatic nuclei. All these are features of anaplasia. Okay, please remember them. So you see, this is a malignant cell and large nuclei, multiple bizarre nuclei. The cells look so bizarre, so abnormal. It does not resemble any normal tissue. Only by the this pink color of the cytoplasm, eccentric appearance of the nucleus, we can think that it can be a skeletal muscle tumor or a muscular tumor, but we are not sure. We need to have some more special stains like immunohistochemistry for the confirmation. Okay, so these are bizarre cells, look very they have got a very bizarre type of a look, the angry type of a look, the pleomorphic type of a look, which are totally dissimilar from a normal cell. No normal cell will look like this, whether it is muscle, whether it is epithelium, nothing will look like this. Okay, anaplastic tumor. Here you cannot make it which type of tumor it is. The cells, they don't have any cytoplasm. The nuclear are arranged haphazardly, and the nuclear shapes and sizes differ. One is a round, one is a spindle. So, and the nuclear are, they have dense chromatin nucleoli, and you see this one. This has a tripolar mitosis. See, this is a tripolar mitosis at the base of this anaplastic tumor. This, so this is definitely not a normal mitotic figure. Definitely not a normal mitotic figure. So this makes it a malignant lesion. Okay. Coming to the difference between the benign and malignant tumors asked in the undergraduate viva table, not for the postgraduates. This is a very basic question. Postgraduates are usually not asked this question. So undergraduates, they may be asked this question. So what are the differences? Clinical and gross features. I always tell my students, start from the clinical findings, the history, the gross findings, then go to the microscopic features always. So clinical and gross features, what it could be? It is encapsulated or well circumscribed. Means there is a capsule around the tumor. That there is a capsule, well circumscribed. It can be benign. Don't always be confused by the gross findings. They may be at times misleading as well. But these are, all the things are indications, or the probability becomes more if you see these type of findings. Poorly circumscribed, irregular boundaries, not capsulated, so that is malignant. Surrounding tissue may be compressed, surrounding tissue may be invaded, means the tumor infiltrates into the surrounding tissue. Here the tumor, though it grows in size, it will compress the normal tissue. Okay, size, benign is usually small. We showed you the example of a lipoma in a patient, small size, and this is a larger size. Secondary changes means there is a redness of the skin, there is a ulceration of the skin. These are called secondary changes. So these are less often seen, more often seen. We showed you the example of malignant peripheral nerve sheath tumor. Here we showed you an example of neurofibroma. Remember? So these are the secondary changes. Microscopic features, very important for a pathologist. Pattern, it resembles the tissue of origin closely, often poor resemblance to the tissue of origin. Basal polarity, all these are the cellular features what we discussed just now related to anaplasia. Basal polarity retained, basal polarity lost, pleomorphism not present, nucleocytoplasmic ratio normal, increased, anisonucleosis absent, present, hyperchromatism absent, present, Mitosis may present, but always typical mitosis, that is bipolar mitosis are there. Here mitosis are increased and generally atypical and abnormal, what we showed you once, what you this last slide. Tumor giant cells may be present but without nuclear atypia, present with nuclear atypia, chromosomal abnormality is infrequent, invariably present, function usually well maintained, may be retained. Yes, okay. Growth rate, slow growth, this comes from the history. Okay, so this growth rate is actually a history which will tell you that you have to ask the patient how long it has been there. Is it growing slowly or is it growing very fast? If it is an intra-abdominal invisible lesion, the patient will not be able to tell you properly. He will only tell you about the discomfort he is experiencing. But if it is a visible lesion, the patient will tell you that this has been there for a long time. We see many patients who have a facial swelling, usually salivary gland pleomorphic adenoma. People do not want to get it operated, thinking that if you get operate the tumor, it will turn malignant, which is a misconception. So you may see such large hanging tumors on the face of the some patients. Some patients will have a large goiter. They don't want to get treated properly, so they will have a large goiter which is there in the front of the neck. So those are the slow growing benign lesions. They do not cause death of the patient. If you see a large tumor which has been there for ages, think that it is a benign lesion most likely. Okay, but there is a but is that if the tumor is there for a long time, it may at times become malignant. So from the benign lesion, malignancy can happen. Okay, so you have to remember these buts also. Metastasis absent. We have exceptions there also, but for all practical purposes, metastasis is a thing for malignant lesion. Prognosis, only local complications caused by compressions, but prognosis is very bad for a malignant lesion, causes death by local and metastatic complications. Please remember this chart. Okay. Now this terminology. What are these omas? We have different, we just uh, came to know that anything with a oma is usually a tumor. Okay, like lipoma, liposarcoma. So lipoma is a benign tumor, liposarcoma is a malignant tumor. So they have oma at the end. But there are some omas which may not be tumor. So those are the examples. What is that? Hamartoma. It is a disorganized but benign appearing masses composed of cell indigenous to the particular site. That is, the cells are there, but they look haphazard, they look disorganized, but they are present where they should be. Okay, আমি ক্লাস নিচ্ছি, আমি একটু পরে কথা বলছি, ক্লাস নিচ্ছি। আচ্ছা, so sorry, so was thought to be developmental malformations, but there is a problem. Problem is that some hematomas have been found to have clonality, and whenever you see clonality is present in a particular lesion, that gives an indication that it could be neoplasm. Okay, so recurrent translocations involving certain genes have been found in hamartomas also. So hamartoma usually was a lesion which was just discarded. Oh, it is not a tumor, so don't think about it. But if you see hamartoma, it is a benign condition definitely, but keep your options open, means the patient should be followed up. Okay, so if the patient is told that you have a insignificant lesion, he will never come to you for follow-up. But if you tell him that please come after 6 months or after 1 year, or if you see any recurrence of the growth, please come to us again, so the patient is alerted. So your duty as a doctor is to alert the patient also. Don't unnecessarily frighten the patient. It is a very bad practice. some of the doctors, I should not be saying, they have a habit of frightening patients. Like they will say, oh, you will die in certain this thing, then that thing. So please never do that. You should tell, the diagnosis should be told. In certain cases, we do not tell the diagnosis to the patient directly. We inform the patient's relatives, because the patient, if is told directly, at times may have a traumatic or a nervous breakdown, may resort to some things like suicidal tendencies may develop. So depending on the mental structure of the patient, the mental toughness of the patient, we tell the patient what disease he or she is having. It is these things, the breaking a news to a patient is very, very important. We at times break the news to the patient, we at times refrain from breaking the true actual news to the patient, but we break the news to the patient's relative. But somebody you will have to confide to, you will have to tell the diagnosis to a person, just cannot write it and in some medical terminology which is not understood by any of the normal people. Okay, so please do not please don't resort to those practices. You have to tell the patient's relatives, you have to tell the patient at times. Okay, so these are all your ancillary things you have to understand. You have to know that practicing medicine is not so easy. You have to be very, very alert. You have to be sympathetic, empathetic, not sympathetic, empathetic towards the patient and their relatives who are experiencing the trauma of the disease. Okay. Now, what is choristoma? Choristoma is a congenital abnormality which is better described as a heterotrophic rest of cell. Example, a small nodule of well-developed pancreatic substance may be found in the submucosa of the stomach, duodenum or small intestine. Okay, so something which should not have been there is present, but it is a congenital anomaly only. It is not a neoplasm. It is not a benign lesion or a malignant lesion. Something which was not to be there becomes there. Okay, so that is called heterotrophic rest of cells, means the rest which developed during the development of the embryo, that remained there and did not move to the site where it should be. So that becomes a heterotrophic rest. Okay, so that is the difference between hamartoma and choristoma. Hamartoma is the indigenous site, but the mass are composed of haphazard cells. Okay, suppose the lung parenchymal cells, the lung has parenchymal cells as well as stromal cells. Okay, but suppose the stromal cells become haphazard, they take up different shapes and sizes, and there is a kind of a growth, and you cannot understand what it is, but it is not a benign malignant lesion also. So then it becomes a hamartoma. Okay, so the example is pulmonary chondroid hamartoma, contains islands of disorganized but histologically normal cartilage, bronchi and vessels. So histologically you can identify if it is a cartilage, if it is a bronchial epithelial cell and the blood vessels, but they are disorganized. You can very well understand once you start seeing microscopic images of a particular tissue, you will understand this difference between organization and disorganization. This comes with practice. I cannot explain it to you in this PowerPoint lecture, but I don't think I have an image of it also. So, but it is something which comes up with practice. You can see the image in the internet or the book. It is there definitely. Dysplasia, what does this mean? The dysplasia means disordered growth. Often occurs in metaplastic epithelium, but not all metaplastic epithelium are dysplastic. Dysplasia term is actually mostly used with epithelium and is characterized by a constellation of changes. The characteristic changes are the same as of a anaplasia. Okay, the same changes, loss of polarity, pleomorphism, high incidence, etc., etc. So in other words, dysplasia and anaplasia, they have very close resemblance. These two words are very closely related. Okay, but anaplasia, whenever we use that term, anaplasia actually means very high level of dysplasia. Okay, so but there is a very, very close similarity between these terminologies, dysplasia and anaplasia. High-grade dysplasias progress to malignancy, while low-grade dysplasias can revert back to normal if the initiating stimuli is withdrawn. This is a very important sentence. Okay, so dysplasia can be reversible also. Okay, but when anaplasia sets in, it is almost irreversible. So that's why low-grade dysplasias, which can be caused due to various things like smoking. Suppose if smoking causes dysplastic change in the epithelium of the respiratory tract, that dysplastic change initially can be reverted back. Okay, so that dysplastic change, if the smoking is discontinued, can be reverted back. But once it reaches the level of high grade dysplasia, then that reversal is not possible. Okay. Metaplasia. This is a very important definition which is asked often in the Viva table. You have to remember the examples also. Metaplasia is a reversible change in which one differentiated cell type, either epithelial or mesenchymal, is replaced by another cell type. This is the definition of metaplasia. It may represent an adaptive change or substitution of cells that are sensitive to stress by cell types better able to withstand the adverse environment. Okay, so the best example, I had shown you this example before also, metaplasia, when I had discussed in general pathology other this changes of the cellular changes. We discussed the metaplasia in details. I remember showing the picture of Shah Rukh Khan, and smoking causes the squamous metaplasia in this respiratory epithelium. I remember that. So anyway, what I want to stress upon is that metaplasia, please remember, is that the one cell type changes to the another cell type, but they are all differentiated cells. That is, means those are the adult cell types. There is no undifferentiation. Okay, okay. So columnar cell changing to squamous cell, or squamous cell changing to columnar cell. So where does it happen? Very classic example of squamous cell replacing the columnar cell or the respiratory lining cell happens in the case of a smokers, chronic smokers. The respiratory tract cells are lined by ciliated columnar. The full name is pseudo-stratified ciliated columnar epithelium. Okay, but the columnar ciliated columnar cells are replaced gradually by the squamous cells in chronic smokers. Where does this reverse occurs? Where does squamous cell change into columnar cell? That happens in Barrett's esophagus. Barrett's esophagus or Barrett's esophagus, we want to pronounce it. So that happens in the lower end of esophagus, in the patients and the persons who suffer from reflux esophagitis. So reflux esophagitis leads to continuous bombarding of the lower end of the esophagus by the gastric juice, and that leads to the change in the squamous epithelium, and it becomes columnar epithelium. Well, it is able to withstand the stress or the adverse environment for the time being. But remember, metaplasia is a double-edged sword. Metaplasia is a double-edged sword. Why? Because this same metaplasia will turn into dysplasia in the long run. That is the catch. Initially, it is able to withstand the adverse environment. So the squamous epithelium, which is replacing the columnar epithelium in the respiratory tract, can withstand the harmful effect of the smoke, the noxious effect of the smoke, the chemicals which are causing damage. It can withstand better. But in the long run, the same squamous epithelium which has replaced the columnar becomes dysplastic and becomes later on changes into squamous cell carcinoma. The Barrett's esophagus, where the columnar epithelium is replacing the squamous epithelium, that is, squamous epithelium is replaced by the columnar epithelium, becomes converted into an adenocarcinoma. So that is the catch. That is the double-edged sword. So there is a question at times, comment on metaplasia is a double-edged sword. So you have to answer all these things. Mesenchymal metaplasia, myositis ossificans, happens in trauma to the muscle. The development of bone within the muscular tissue is called myositis ossificans. Full name is myositis ossificans traumatica. Differences between carcinoma and sarcoma. Again, an important question often asked in the Viva table. It used to be asked previously in the theory examination also, but nowadays I don't see it so much. But Viva table, it is often asked by the examiner. So, what are the differences between a carcinoma and a sarcoma? Carcinoma is a malignant tumor of the epithelial tissue. Sarcoma of the mesenchymal tissue. Incidence: carcinoma very common, less common. Age: more common in middle and old age. Please remember this thing, because carcinoma usually is a thing of elderly, does not usually happen in young people. See, there are exceptions in all these categories. Okay, there are exceptions, but you remember what is the most common thing. Sarcoma more common in younger age group. Growth rate: carcinoma relatively slow, rapidly growing tumor, which are sarcomas are. Microscopic appearance: groups of malignant epithelial cells supported by well-formed and reactive stroma. Hemorrhage and necrosis less common, more in anaplastic carcinoma. Okay, that is, hemorrhage and necrosis may be seen more in anaplastic carcinoma, whereas here diffuse and infiltrative growth of malignant mesenchymal cells with poorly formed stroma. Why poorly formed stroma? Because the cells become diffusely growing, because the stroma is less, and at times you cannot identify the one cell from the another cell. They are present in sheets. Okay, and they're like a syncytium. One cell boundary cannot be distinguished from another cell boundary. You can only see the nuclei which are scattered throughout. Okay, so that is the poorly formed stroma. Hemorrhage and necrosis more common in sarcoma. Tumor giant cells are more common in sarcoma. Metastasis: carcinoma, lymphatic metastasis early, hematogenous late, and sarcoma, lymphatic uncommon, hematogenous common. So this you can write it like this. For carcinoma, lymphatic metastasis is a common pathway, and for sarcoma, hematogenous metastasis is common pathway. Okay, hematogenous means through the veins. Okay, and lymphatic channel, you can understand, it goes to the regional lymph nodes, and through the veins, where does it go? It goes to the areas which are highly supplied by wells. Example I am giving you: suppose a gastrointestinal stromal tumor, GIST, or even say epithelial tumor of the intestine. It will go to the liver through the portal tract. Okay, so the portal system, the portal venous system, can take a malignancy of the intestine to the liver. So that is called a hematogenous route of spread. Fine. Lymphatic spread very common. Breast carcinoma spreading through the axillary lymph node. It is a lymphatic spread. Radiosensitivity. The carcinomas are radiosensitive. Sarcomas are not. So for sarcomas, the treatment is actually very difficult. Initially, if the tumor is small, you can just excise. There is a wide local excision which is done. And these days, specific chemotherapeutic regimens are there, which are based on the particular type of genetic variations, but at times they are not so effective. Okay, so carcinomas are easier to treat. So this is the 5 most common primary cancers in the world, taken from Harsh Mohan. So the lung in men, it is lung, prostate, colorectum, urinary bladder, and lymphoma. In women, it is the breast, cervix, lung, colorectum, endometrium lymphoma, and in children, acute leukemia, central nervous system tumor, sarcoma of the bone, that is osteosarcoma, endocrine tissue, and soft tissue sarcomas. As I told you, sarcomas are more common in children. You can see the example: bone sarcoma, soft tissue sarcomas, and leukemias. Leukemias are very common in children. The same thing which is there, I don't want to repeat it. Now, invasion and metastasis. I have some time, so I will finish it off. So, benign tumors grow as a cohesive expansile masses that remain localized to the site of origin. They do not metastasize. The tumor mass does not go to another area. Okay, and they have a rim of compressed connective tissue along with atrophied parenchymal cells, the capsule. In some, it is lacking. In hemangiomas, for example, hemangiomas, the capsule may be lacking, but still the behavior, the pattern of growth, the rate of growth, all these are indicative of its benignness. That is a hemangioma. Okay, where the capsule is lacking. In malignant tumors, invasion, infiltration, destructive, all the bad characteristics. So, malignant tumors, you can definitely identify it is the bad boy. Of tumors, benign tumors may be a good boy, or you can say not so good, not so bad boy, but malignant tumors are definitely bad boys. Okay, so and cancer, they extend through the tissue spaces, permeate the lymphatics, blood vessels, perineural spaces, and they may penetrate the overlying skin, bone, wherever they can lay their hands on, they will infiltrate and destroy the area. So that is the worst thing to happen to a person, a malignant tumor. So these are the examples. So this is example of a leiomyoma, that is the smooth muscle, benign tumor of the smooth muscle. This is the uterine cavity, this is uterus, and this is a leiomyoma or a leiomyoma. Okay, so this has happened in the cervical region, and you see well circumscribed round tumor, and from the look only you can make out that there is a capsule which is there surrounding the tumor, and it is circumscribed, means it is well contained within the capsule. Okay, so had it been a malignant tumor, what would you have seen? This capsule would not have been there. There would have been areas of hemorrhage and necrosis, and these comes you see how do they look like, and how do they see. You have to actually see the specimen to understand or have a better idea. Okay, most of the undergraduate students, they can see the specimen in their museum, and though they may not be handling the specimen so frequently like the postgraduates who have to do the grossing by themselves, so the idea can be you can have an idea by seeing the specimen only. Okay, so this is the leiomyoma. Metastasis are tumor in plants which are discontinuous with the primary tumor. If it is going directly, it is called invasion. If the tumor ball or a tumor, say the ball of the tumor goes away and lands up in a different area, that thing is called metastasis, and hallmark of malignant tumors. The invasiveness of the cancer permits them to penetrate into the blood vessel, lymphatics, and body cavities, providing them the opportunity for spread. Except for gliomas and basal cell carcinomas. Okay, so these are exceptions. Glial tumors, that is the astrocytomas, the oligodendrogliomas, they are basically malignant tumors, but they do not metastasize usually. Similarly, a cancer known as basal cell carcinoma of the skin, which only invades locally. Okay, so in a way, they are good tumors in the sense that they do not go to different places. But the problem with glial tumors are there is that since they're happening in brain, so this brain is such a sensitive area. Even a benign tumor which is there in some deep seated area can be difficult to be excised in toto. So if you cannot excise the mass in toto, that will recur and that will keep on spreading, and ultimately death can happen. Whereas for basal cell carcinomas, it's a better in the way that it happens in the sun exposed area where you can see the lesion. If you can excise it properly, you can give proper radiotherapy, the chances for the patients are much better. That is, the prognosis is better. And metastatic spread strongly reduces the possibility of cure. The more the metastasis has happened, the chances of cure are reduced considerably or significantly. Pathways of spread, again asked in the Viva table. This again all these chapters of all the topics of neoplasia, I am again telling is very, very important because you may be facing which nobody knows. These are very common questions for the minute. What are the pathways of spread of it by tumor? Dissemination occurs through one of the three pathways: direct seeding into the bodies of lymph spread and hemat spread. Okay, seeding of the body of malignant presents when next the cavity or space, the peritoneal cavity, pleural cavity, pericardial cavity. These are the spaces, open spaces. Okay, and happens in case of carcinomas, ovarian carcinomas. They have a tendency to go and seeds from the appendix, and that tumor and spreads throughout the peritoneal cavity and makes it in a gelatin like mass, a jelly like mass. The name given is pseudomyxoma peritonei, peritoneal seeding of the tumors. So this is the peritoneum, and you see the malignant cells have come and spread into the peritoneal tissue. Lymphatic spread, most common pathways for the carcinomas, but sarcomas may also use this route. Okay, emphasis on lymphatic spread for carcinomas and hematogenous spread for sarcomas is misleading because ultimately there are numerous interconnections between the vascular and lymphatic systems. You have to remember these things. So though we commonly say that for carcinomas they spread through lymphatic, sarcomas they spread through hematogenous route, but actually when distant metastasis or late metastasis starts happening, that is the tumor has advanced beyond a particular proportion, so all forms of metastasis keep on happening through blood vessels, through lymphatics, through everywhere. Okay, the pattern of lymph node involvement follows the natural routes of the lymphatic drainage. Naturally, the breast cancer will first, the chances of breast cancer metastasizing to a lymphatic lymph node is the axillary lymph node first, because that is the area of drainage. It will not go to the inguinal lymph node. Okay, so that is the route, natural route of lymphatic drainage. Understand? So local lymph nodes, however, may be bypassed. That is called skip metastasis. I say everywhere there are exceptions, isn't it? Because venous lymphatic anastomosis, or because of inflammation or radiation and obliterated the lymphatic channels. So these may be leading to skip metastasis. So you can, the axillary lymph node may be skipped and you can see a metastatic mass in the supraclavicular lymph node. Okay, so that is called skip metastasis. But if it is there in the axilla as well as in supraclavicular region, that is not skip metastasis. That is why, because it has advanced, the metastasis has advanced, gone to a further place. But if you see only in a supraclavicular region in a case of breast cancer or a gastric cancer and no lesional involvement of lymph nodes is there, then you say it is a skip metastasis. So this is a lymph node. You see small dot like cells. These are the lymphocytes, and this is the squamous epithelial cell which has metastasized. This is a glandular epithelial cell. You see the glands which are there in the lymph node. So this is a adenocarcinoma. This is a metastatic squamous cell carcinoma. So we have come to the end of the topic. Thank you so much. If you have still any doubts, this I can answer you through our this site. Thank you so much.
Thank you, Dr. Palash. Excellent lecture and very basic. It was very essential. There is a question by Dr. Saria Ansari in the YouTube. When we talk of columnar metaplasia and lung, then why the first step is basal cell hyperplasia? I'll just tell you. Can I answer?
Yes, sir.
Basically, basal cell are the progenitor cells. Basal cell hyperplasia will lead to any other metaplastic formation, or maybe just pure simple hyperplastic formation. So first step of any transformation will be at the basal level only. So that is why the first step is basal cell hyperplasia, and subsequently if it is transforming into the same cell line, then it is pure hyperplasia, but if it is changing into a separate cell line, then it is metaplasia. And if the cell line is becoming abnormal, then it is dysplasia. Is it?
Yes, sir. Yes, sir. Yes, sir.
Thank you so much, Dr. Palash. Thank you so much.
Thank
The
you,
next
sir.
the next session will be neoplasia session 2, isn't it?
Yes, sir. Yes, sir.
Thank you. Take care. Bye bye.
Thank you, sir. Thank you.